So what I mean by that is, I think when you're typing, when you're sitting, think about the joints that are in a position, joints that are moving. What types of joints are those? What types of actions do those joints do? And what muscles move those joints to do that action? What nerves innervate those muscles? What vessels vascularize those regions of the body? You can draw out maps on yourself. You can take a picture of yourself and then draw it out in a digital format, whatever you want to do. If you're a kinesthetic learner, start with something simple. Like right now, I want you guys to just wiggle your toes a little bit for me. Press your toes down into the carpet or your hardwood floor or your laminate flooring, whatever, your shoes, whatever you're wearing on your feet or not wearing, and just wiggle your toes around a little bit. So let's think about that anatomy. What types of joints are those interphalangeal joints? How many interphalangeal joints are there? There's a distal and a proximal interphalangeal joint. Those are going to separate the phalanges. There are 14 phalanges in your toes, and all of those are hinge joints. And if you flex those phalanges and dig them down into the ground, what muscles are you using that cross underneath the foot? The intrinsic muscles of the foot are all innervated by the tibial nerve, and all of those muscles that move those proximal and distal phalanges are all innervated by the tibial nerve, and a lot of them come from the calf. Those are extrinsic muscles of the foot. And if you think about those, we talked about the muscles of the foot and the different layers of the muscles of the foot. I would be familiar with what muscles are found in each layer of the foot, and those 4 layers of the foot, 3 layers depending on the reference that you look at. Of course, one of my favorites in that foot is the quadratus plantae. That's going to help shorten the foot or help maintain that arch. But other muscles that go into those little digits in the foot are going to be extrinsic muscles of the foot and of the digits. All of those flexors, remember, wrap around the medial malleolus, that tarsal tunnel. Let's see if we can get that up in here. So there's your tarsal tunnel right there. And around that tarsal tunnel, you had Tom, Dick, Artery, Nerve, Harry. Make sure you know the real anatomical names of those, what nerve and what artery travel with those, where those attached in general, that those flexors of the toes are attached on the posterior aspect of the calf. They're all innervated by the tibial nerve. If we move into the lateral compartment, we're going to do actions like eversion and some plantar flexion. Give me 20 seconds to go grab a tissue so I can wipe my nose. And we're back. We have the everters of the foot, that lateral compartment of the leg running next to the fibula. That's going to be your peroneal group. Peroneus longus, peroneus brevis. Peroneus longus goes underneath the foot, attaches at the base of the first metatarsal along with tibialis anterior. The fibularis brevis is going to wrap around the lateral malleolus, attached to the base of the fifth metatarsal, same place that fibularis tertius attaches from the anterior compartment. All of those muscles in the lateral compartment of the leg, all along there, those are both innervated by superficial fibular nerve. If we move from the lateral compartment to the anterior compartment, all of the muscles in that anterior compartment are innervated by the deep fibular nerve. They're going to do things like dorsiflexion and extension of the digits in the lower extremity. That lateral compartment, of course, innervated by superficial nerve, superficial fibular nerve. Anterior compartment is going to be innervated by deep fibular nerve. The muscles in that anterior compartment, tibialis anterior, extensor hallucis longus, extensor digitorum, and fibularis tertius. Where do those go and what do they do? Can we palpate those tendons? If you bring your knee up towards your chest, do a little bit of dorsiflexion, and with that dorsiflexion, do a little bit of inversion of the foot or rolling onto the lateral aspect of the foot. that tibialis anterior tendon is going to stick out really far, and then relax that just a little bit. And next to that tibialis anterior, take your big toe and pull that big toe up. While you're palpating, you should be palpating. Then if you're only picking up your big toe, your great toe, then you're working the extensor hallucis longus. You should feel that tendon. So there's the tendon of tibialis anterior, and there's the tendon of flexor hallucis longus. If I feel right in between there and I press down onto the top of the foot, then I'm palpating the dorsalis pedis. Pedis meaning foot, dorsalis being the dorsal aspect. That is the termination of the anterior tibial artery. Remember that anterior tibial artery had to pierce through the interosseous membrane. It started on the posterior side when the popliteal artery split into an anterior and a posterior tibial artery. That posterior tibial artery, of course, traveling with the tibial nerve, wrapping around that medial malleolus with the Tom, Dick, artery, nerve, Harry. If we move up into the knee, we flex and extend the knee, but the knee also does a little bit of twisting, right? That popliteus had to unlock the knee. Again, popliteus also innervated by the tibial nerve. All of those muscles in the posterior compartment innervated by tibial nerve from superficial to deep. You've got gastrocnemius, plantaris, soleus. Gastroc and soleus come together to form the triceps surae. Those both insert at the calcaneal, at the calcaneus via the calcaneal tendon, along with the plantaris. Deep to that is where we would see that posterior tibial artery and the tibial nerve. That posterior tibial artery is going to give off the fibular artery that's going to head out lateral towards the flexor hallucis longus. The deep compartment of the calf is going to be flexor hallucis longus from the lateral side, tibialis posterior in the middle, and flexor digitorum is going to be the most medial muscle belly. Keep in mind that those muscle bellies are not in the same order as the tendons as they wrap through the tarsal tunnel in the ankle there. The knee joint is a condyloid or ellipsoid joint because of that little bit of rotation that occurs at that knee joint. We move into the patella. The patella attaches to the tibia, the tibial tuberosity, via the patellar tendon. Nope, patellar ligament. Patellar tendon is going to be between the patella and the quadriceps muscles. If we're palpating that patella, let's move just a little bit medial, and there we should be able to palpate our medial meniscus. Go just distal to that, to the pes anserine. That's going to be an attachment point for 3 different muscles from 3 different compartments in the thigh, including the sartorius, gracilis, and the semitendinosus. Each of those gets a different innervation based on the compartment from which they come. Let's move from that pes anserine. Let's go lateral. Let's go feel over the tibial tuberosity and then into the lateral proximal anterior tibial shaft at Gerdy's tubercle. That's going to be an attachment point for a little bit of that IT band coming down. IT band might have a couple of fascial slips into the head of the fibula. Head of the fibula, of course, if we take our x-ray vision and we go into the lateral fibula, we're going to have the head of the fibula, attachment of fibularis longus. You've got the deep fibular nerve that wraps around the head of the fibula. Yeah, and that deep fibular nerve is going to meet up with the anterior tibial artery. Oh, let's see, we've got some ligaments in there. We've got fibular collateral or lateral collateral ligament, the medial collateral ligament, the ACL and the PCL, and then our 2 menisci in between the femur and the tibia as well. Let's go back to that patella. From that patella, palpate proximally. I'm going to try and move this computer around a little bit and see if we can get a little better view. We're going to turn this into a palpation by movement. How are we doing here? All right, so we're at the tibia, or we're at the patella there. patellar attaches to the quadriceps by the patellar tendon. The most superficial muscle in this anterior compartment, this is the anterior compartment, of course. Everything is innervated by a femoral nerve, L2 through L4, except for pectineus, which is sometimes innervated by the obturator nerve a third of the time. So that sartorius, the most superficial, goes from the ASIS down to the pes anserine. And the other muscles there are going to do flexion of the hip in general and extension of the knee. There's flexion of the hip, there's extension of the knee. That includes the quadriceps. There's 4 quadriceps, largely accepted, with some variation because of novel research in the last couple of years. Those 4 quadriceps are the rectus femoris. That's the only quad that crosses 2 joints, so it does hip flexion and extension of the knee. Vastus lateralis, vastus medialis, and then deep 2. All of those is going to be, especially deep 2, that rectus femoris, is going to be the vastus intermedius. That vastus lateralis is largely covered by the IT band. IT band comes from the TFL and the upper fibers of the glute max. The TFL, glute min, and glute med are all innervated by the superior gluteal nerve, and the glute max is innervated by the inferior gluteal nerve. If we cut open the glute max and reflect that open, we'll be able to see the lateral rotator group, which includes the piriformis, with the sciatic nerve piercing out either through the muscle or at the inferior border of the muscle. That sciatic nerve has a tibial division and a fibular division. Tibial division is going to innervate almost everything in the posterior compartment. Posterior compartment of the leg is going to be the hamstrings, where you're going to do extension of the hip and flexion of the knee. The hamstrings from lateral to medial are going to be the bicep femoris. There's 2 heads. The long head is a true hamstring. It crosses the hip and the knee. The short head is going to go to linea aspera, the intermuscular septum, and a couple other places along the way there. That short head is our exception to the rule in the posterior compartment. It's innervated by the common fibular nerve or the sciatic nerve fibular division. The medial compartment is innervated by the obturator nerve. That medial compartment is largely going to do things like adduction. So with those adductors, we have the gracilis, which is going to be the most superficial, another one of those muscles that inserts at the pes anserine, proximal medial anterior tibial shaft. But here we get our innervation from the obturator nerve, L2 through L4. So we've got gracilis, which goes to the pubic symphysis, and then down to the pes anserine. We get that out of the way, and then we'd be able to see the adductor longus. Adductor longus is that muscle that we cut through in lab, and when we cut that muscle belly open, we got to see adductor brevis. Brevis had the sandwich wrap around it. We saw a little bit of the obturator nerve pass around there, and superior to that, so that was adductor brevis. Superior to that is going to be pectineus. That was our sort of amorphous rule breaker in the anterior or medial compartment, attaching to the pectinate line on the femur. And then we have adductor magnus. Adductor magnus has 2 heads. It's compound muscle. The adductor head is innervated by obturator nerve. The hamstring head is innervated by sciatic nerve tibial division. That hamstring head attaches at the adductor tubercle. Right next to that adductor tubercle, we have the adductor hiatus that allows for the passage of the femoral artery through that adductor hiatus. Femoral artery, once it passes through the adductor hiatus, becomes the popliteal artery on the backside. That popliteal artery is going to give usually about 5 branches off of there. The geniculars that wrap around the knee and form a vascular anastomosis around the patella. As we move up into the hip, then we have the lateral rotators and medial rotators of the hip. The lateral rotator group, of course, we talked about the piriformis just a little bit. That's going to be the biggest one. That's your big pain in the ass. Inferior to that piriformis, the other lateral rotators of the hip that we saw were the superior inferior gemellus, the obturator internus, obturator externus. We didn't actually see the obturator externus in lab because its dissection is a little bit too deep. But the obturator internus and the obturator externus get their name from where they attach on the pelvis. The obturator internus attaches at the internal surface of the obturator membrane and that obturator foramen in the pelvis. The obturator externus is going to start on the outside surface of the os cox and then wrap around and attach at that femur. Inferior to that, we would have the quadratus femoris, which will attach to the quadrate line. That's that rectangular, flatter muscle in the proximal femur involved in lateral rotation of the hip. All of those are innervated by the sacral plexus. You're going to learn more detail on each of those lateral rotators in peripheral nervous system neurology with Dr. T next turn. Around that head of the femur, we also saw an important anastomosis called the cruciate anastomosis. The cruciate anastomosis is going to result from branching of the vessels that come off the femoral artery. Femoral artery is the termination of the external iliac when the external iliac passes across the inguinal ligament. Inguinal ligament occurs at the L1 dermatome level. That cruciate anastomosis is made up of the lateral femoral circumflex, medial femoral circumflex, first perforating branch, and a branch off of a gluteal artery. Review all of the information from that. Other things that we might want to be aware of are going to be cutaneous distributions of nerves. So we've got lateral femoral cutaneous out here. We've got obturator in here. All of this is going to be femoral. And then up here we've got cluneal. And then we've got sciatic. And most of the rest of those named nerves are going to follow along with the region. I would point out that the deep fibular nerve innervates the skin in between the first and second toes, right there. The rest of this top of the foot is going to be cutaneous distribution of the superficial fibular nerve. We talked about the abdominal muscles, and the abdominal muscles, again, from superficial to deep, we've got the external oblique, the internal oblique, and then rectus abdominis, transversus abdominis, and then the peritoneal lining. That transversus abdominis is all about compression of the abdominal contents. The internal oblique is unique because there's a hole in it right down here that allows the rectus abdominis to move from being sandwiched by the aponeurosis of the internal oblique. Then that aponeurosis closes as the rectus abdominis goes posterior, and all of those layers of the aponeuroses move in front of the rectus abdominis at that arcuate line in between the umbilicus and the pubic symphysis. We moved from the lower extremity anatomy, and that was not every single detail, but a lot of the details. We moved from that lower extremity anatomy into the upper extremity anatomy, and we started with the posterior musculature. The posterior musculature, we had the thoracodorsal nerve and artery that served the latissimus dorsi, meaning broad back muscle. Superior to that, we had the trapezius motor innervation by cranial nerve 11 and sensory innervation done by C3, C4. C3, C4 we see come up quite a lot. It's part of the cervical plexus. Cervical plexus is going to be C1, 2, 3, 4. And out of that cervical plexus, we saw the ansa cervicalis, that loop in the neck just deep to the SCM. That ansa cervicalis is going to innervate some of those hyoid muscles that we're going to get to when we get to block 3 material. But let's go back to the traps, lats, we reflect those. And in that same region, we had our rhomboids, which are going to help retract those scapulae, pull those scapulae together in the back. The rhomboids and the levator scap are both innervated by the dorsal scapular nerve. That's C5. Dorsal scapular nerve emerges in between the muscle belly or through the muscle belly of the middle scalene. That middle scalene and the anterior scalene are going to be the borders of the brachial plexus as it emerges in and headed towards the upper extremity. Brachial plexus made up of nerve segments C5 through T1. The brachial plexus, roots, trunks, divisions, cords, and branches. Roots, cords, and roots. Robert Taylor, trunks, divisions, cords, branches. In that order. We saw the cords while we were in gross anatomy for that upper extremity dissection. The lateral cord and the medial cord. From there, from the lateral cord and the medial cord, we saw the lateral and medial pectoral nerves that are going to innervate pectoralis major. Medial pectoral nerve also innervates pectoralis minor. Pectoralis minor attaches at the coracoid process. There are 3 muscles that attach to the coracoid process. That's the pec minor that is going to attach at ribs 3, 4, 5, sometimes 6. The coracobrachialis in the anterior compartment, and the short head of the bicep. Coracobrachialis, short head of the bicep, and pectoralis minor all attach at that coracoid process of the scapula. If we follow those cords out, we had a lateral and medial cord contribution to the median nerve, and then the posterior cord, which gave rise to the radial nerve and the axillary nerve, are going to emerge from the posterior cord. That posterior cord gets its name because it's posterior to the axillary artery. In the axillary artery, we saw the thoracoacromial trunk, the lateral thoracic artery, which meets up with the long thoracic nerve to innervate serratus anterior that helps hold the shoulder blade to the rib cage. From that lateral thoracic, then we continue out. Then for vessels, we saw the subscapular. Subscapular artery is going to get a scapular circumflex, which helps form an anastomosis around the scapula. And then that subscapular artery would continue down as the thoracodorsal headed towards the latissimus dorsi. If we continue that artery out, that axillary artery is going to end right about teres minor, teres major. I don't know. There's a lot of debate on where that axilla ends. And then we get into the brachial artery. We felt the brachial artery here. If we push the bicep out of the way, it's in between bicep brachii, brachialis. And as long as we're talking about bicep brachii, brachialis, and coracobrachialis, those are all innervated by the musculocutaneous nerve, C5 through T1 segments. Musculocutaneous nerve, all 5 of those. So we felt that brachial artery there. The brachialis was a little bit of an exception in that anterior compartment of the arm because it was dually innervated. It gets innervation from the musculocutaneous nerve, but it also gets innervated by the radial nerve. The radial nerve passing through the triangular interval with the profunda brachii lies in the radial groove. That axillary nerve that we saw come through that quadrangular space travels with the posterior humeral circumflex. Posterior humeral circumflex, anterior humeral circumflex are going to wrap around the head of the humerus and help form an anastomosis there. The borders of that quadrangular space, you've got the surgical neck of the humerus, the long head of the tricep, the teres major, teres minor, teres minor innervated by axillary nerve, segments C5 and C6. Teres major innervated by lower subscapular nerve. Lower subscapular nerve also innervates subscapularis, which we saw deep to that subscapular artery that branched off the axillary artery right here. Subscapularis is innervated by lower and upper subscapular nerve. It's the only rotator cuff muscle that does internal rotation. The teres minor infraspinatus both do external rotation, and the supraspinatus does abduction for the first 15 to 30 degrees. That's innervated by suprascapular nerve that travels through the suprascapular notch, and that suprascapular notch is covered by the suprascapular foramen. That suprascapular nerve also innervates the infraspinatus, one of those rotator cuff muscles as well. And everything in this posterior compartment of the arm is innervated by the radial nerve, except for the long head of the tricep. Long head of the tricep is the only head of the tricep that crosses both the elbow and the shoulder. Because it crosses the shoulder, long head of the tricep also helps with extension of the shoulder there. If we continue down into the elbow, there's the olecranon process on the ulna. And then if we flex and extend the elbow, that elbow is a ginglymus joint or a hinge joint as well. We had our ball and socket joint up here and the glenohumeral joint that allowed us for external, internal rotation, circumduction, flexion, extension, lateral extension, and we did adduction, abduction. Yeah, sweet. So we get into that elbow, and at least the humeral-ulnar joint is just ginglymus flexion extension. It's the proximal radial ulnar joint that allows for pronation and supination. In this area here between the brachialis and brachioradialis, the radial nerve is going to emerge. Radial nerve splits into superficial radial nerve and deep radial nerve. Superficial radial nerve runs deep to brachioradialis, 45 degrees between the two, high repetition and low weight for flexion of the elbow. The deep radial nerve goes underneath the supinator muscle and is a common entrapment point for that. The radial nerve continues down and is going to innervate all of the extensors of the forearm and the outcropping to the thumb. The extensors in the forearm are going to be extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor indicis, extensor digiti minimi, and then the outcropping to the thumb that forms the anatomical snuff box. From proximal to distal, we're going to have the abductor pollicis longus, extensor pollicis brevis, and then extensor pollicis longus out there. In that anatomical snuff box, we should be able to feel the scaphoid being in the proximal lateral row of the carpals. Scaphoid, lunate, triquetral, pisiform, and then trapezium, trapezoid, capitate, and hamate. Those are both going to, or all of those are going to articulate with each other. They form a carpal dome. Know the names of them in the proximal row and the distal row, and keep in mind that from anatomical position, whatever mnemonic device you use to remember all of those joints, starts with the lateral proximal row, not the medial proximal row. So keep that in mind. It starts on the radial side. We'll come back to that hand in just a second. Let's go from that posterior compartment of the forearm there. Oh, we forgot about our anconeus, that tiny little deltoid or triangular shaped extensor of the elbow. And there we'll be able to see where that anconeus is located. So there's anconeus, extensor of the elbow, also innervated by radial nerve. In the anterior compartment, almost everything is innervated by the median nerve. Median nerve comes down in between bicep brachii and brachialis, and then it goes through the antecubital space right here. It goes in between the two heads of the pronator teres, a common entrapment point for that median nerve. Pronator teres is going to do pronation, and pronator teres is going to almost share an attachment point with the rest of those common flexors of the forearm. For those flexors of the forearm, we had the flexor carpi ulnaris, pronator teres, palmaris longus, flexor carpi radialis, and then deep to that we saw the flexor digitorum superficialis, the flexor digitorum profundus, flexor pollicis longus. Flexor digitorum superficialis, profundus, and flexor pollicis longus are the 9 tendons that travel through the carpal tunnel. Carpal tunnel is bordered anteriorly by the flexor retinaculum. The 9 tendons that travel through there travel with the median nerve. The median nerve innervates 3 muscles into this thenar eminence. I would know what those 3 muscles are, be able to pick out either which one is innervated by the median nerve or which one is not. Opponens pollicis being one of those 3 muscles innervated by the median nerve. The exceptions to innervation in the anterior compartment of the forearm are the flexor carpi ulnaris. Flexor carpi ulnaris and the 2 flexor heads of flexor digitorum profundus are both innervated by ulnar nerve. Ulnar nerve T1 and C8, maybe C7. I'm not going to count you wrong on that, but it's multiple choice, so you're unlikely to see that C7 segment listed in the ulnar nerve options. I think that was a lot of the nerves and muscles. I probably missed a few things, and that's okay. We're going to go into axial skeleton. From the axial skeleton, we talked about paraspinal muscles. I would especially like us to keep in mind the clinically relevant things like scalenes, suboccipital muscles, low back muscles, intrinsic muscles of the back, which are going to play such an important role in your clinical experience later on in life. And these suboccipital muscles, we have from the EOP, the trapezius is going to lay on top of there. Then the next layer, we have the splenius group. Splenius are going to have fibers going out, and the splenius group, there are 2 parts to it. Splenius cervicis, which attaches to the TPs of the cervical vertebrae, and splenius capitis, which goes up to the mastoid process. We reflected both of those virtually, and then we saw the semispinalis capitis, the fibers running longitudinally up to the superior nuchal line or superior nuchal ridge. We reflected those, and then we got into the more suboccipital muscles. So take a contact, find that EOP, and with your other contact, find the spinous process of S2. That spinous process of S2 is going to be the attachment point for rectus capitis posterior major, the obliquus capitis inferior. Those are 2 of the 3 muscles involved in the suboccipital triangle. The other muscle is going to run along the base of the skull. So from that EOP, move lateral about 1.5 inches, and then just run your thumb, press really deep along the base of the skull. You're following along the course of that superior oblique muscle. Superior obliquus capitis, or capitis superior oblique. That's going to attach to the transverse process of C1, and the obliquus capitis inferior, superior, and rectus capitis posterior major are going to create the borders of the suboccipital triangle. In that suboccipital triangle, suboccipital nerve and the vertebral artery, part of the suboccipital muscles, but not part of the suboccipital triangle, go right along the midline and go past that rectus capitis posterior major, go all the way and try and feel that posterior tubercle of C1. Dig your thumb in there, press really hard, tuck your chin to the roof of your mouth, and tuck your chin, press your tongue to the roof of your mouth, and then push back against that contact, and then you'll actually be able to palpate the rectus capitis posterior minor. Rectus capitis posterior minor has a myodural bridge to the dura mater, one of the fibrous layers surrounding the brain and the spinal cord, and it creates a bridge between the muscular fascia and the dura mater. We move from those suboccipital muscles. Let's go down into the paraspinal muscles. The paraspinal muscles, remember, we had to reflect the rhomboid major, rhomboid minor. Underneath that rhomboid major, rhomboid minor, we saw the superior posterior, serratus posterior superior, that was going to attach at ribs 2, 3, 4, 5, innervated by intercostal nerves 2, 3, 4, 5. And then we reflected latissimus dorsi. Latissimus dorsi, fibers running the same direction. Deep to that were the serratus posterior inferior. Those were the clinical application of having a side ache or a side cramp while running. It is usually going to involve that serratus posterior inferior. We reflected those, and then we saw the muscle fibers running up and down the length of the spine. From the outside in, or from lateral to medial, we saw the iliocostalis that attached to the ribs, the longissimus column that includes all the way up to longissimus capitis, attaching up to the head. And then medial to that, running all along the spine, between the spinous processes, was the spinalis croup. We reflected all of those, and then we saw the multifidi. Multifidi in the lumbar spine are going to go attach at the mammillary process. All multifidi go between 2 and 5 in vertebral segments. And then deep to that multifidus, we saw intervertebral segments. The intervertebral segments, we saw like intertransversarii, between the transverse processes, the interspinales that traveled in between the spinous processes, and then the long and short rotators, or rotatories, rotatories longus and rotatory brevis. The rotatory longus go between 2 non-adjacent segments. The brevis, or the short rotators, went in between neighboring segments, so like from T1 to T2, for example. I'll let you review the anatomy of the vertebral segment on your own, but there's a body, the pedicles extending from posteriorly from that, and then the transverse process, the lamina, meet at the spinous process, and all of those pedicles and those laminae create the vertebral foramen, or the central canal, or the vertebral arch. All of those things mean the same thing. That's where the spinal cord is located. That spinal cord is going to end at about the T12 or L1 vertebral segment, or iliac crest and rib number 12. Follow along those ribs all the way up to the T12 vertebral segment, and then go just a little bit down. That's where your spinal cord ends right now. We're going to talk more about that at the end of gross anatomy too. But let's visualize that spinal cord up into the brainstem. And at the spinal cord levels from T1 to L2, 3, you're going to have so let's take a cross section right through there. Let's look at that. And in that cross section, you're going to have gray matter that makes sort of an H shape. And that H shape in the gray matter leaves white matter in the surrounding area. That white anterior white column, the dorsal white column, is going to be part of the dorsal column medial lemniscal tract that's going to take information up to the brain. And the anterior and lateral columns are mostly involved in descending tracts, bringing stuff back down. Oh, let's zoom back out. We were all the way down into the spine. Let's zoom back out a little bit. Let's talk about some anterior and lateral musculature and innervations. So we have our SCM platysma. Is that guy right there? So there's platysma. We reflect that platysma. We have the SCM, sternocleidomastoid, and the traps, of course, both innervated by cranial nerve 11. For motor innervation, at least, the sensation across here was transverse cervical nerve and then supraclavicular nerve. That's going to be C2, 3, 3, 4, and then down into C5 when you get across the deltoid right there. In that region of the neck, let's find the hyoid bone. Palpate that hyoid bone, but not too aggressively. From the hyoid up to the mandible, where you're going to have the suprahyoids. There's the digastric muscle, the mylohyoid attaching to the mylohyoid line, the genial hyoid deep to that, and then the stylohyoid in splitting between the two bellies of the digastric. The infrahyoid muscles from the hyoid down, the most superficial is going to be the omohyoid that's going to attach at the superior scapula. The sternohyoid goes from the sternum to the hyoid. The sternothyroid goes from the sternum to the thyroid cartilage, and then the thyrohyoid from the thyroid cartilage up to the hyoid. There are 4 suprahyoids and 4 infrahyoids. Almost all of them are named for their origin and the insertion. We mentioned our deep neck flexors, the scalenes. We talked anterior and middle scalene. Anterior scalene attaches at the scalene tubercle on rib number 1. Middle scalene attaches at rib 1 and rib 2. And posterior scalene goes to rib number 2 for those muscles there. We talked about reflexes, flexor reflexes, or withdrawal reflexes, deep reflexes or deep tendon reflexes, contralateral being the same side, ipsilateral being opposite side. Ipsilateral usually went with a crossed extensor reflex. Contralateral was a crossed extensor reflex. Ipsilateral was a flexor reflex. So if I touch something hot and I pull that back, that flexion in my elbow was a withdraw reflex. It happened on the same side as the stimulus or the sensory input, so it's an ipsilateral reflex arc. Contralateral reflex arcs at the same time are going to cross over to the other side and cause the extensors to react in an opposing action. We saw that when you stepped on a Lego, for example, and one leg went up and one leg went into extension. We talked about cranial nerves at the end of our neuroanatomy. There are 12 cranial nerves, pairs of cranial nerves, and we've got cranial nerve 1 is olfactory. That is going to be picked up by the olfactory nerves and the olfactory mucosa. It goes through the ethmoid bone at the cribriform plate into the olfactory bulb, which is the front of the cerebrum. Cranial nerve number 2, optic nerve, that's visual input from coming from the eye. 3 was oculomotor, movements of the eye. Not all movements of the eye, though, not all muscles of the eye. The cranial nerve 3 is going to innervate the intrinsic muscles of the eye as well. The cranial nerve 3 parasympathetic innervation to the intrinsic muscles of the eye is going to reduce the diameter of the pupil or reduce the amount of light that comes into the eye. So cranial nerve 3, oculomotor, is constriction of the pupil and most ocular movements. The ocular movements that are not innervated by cranial nerve 3 are innervated by cranial nerve 4, trochlear nerve. That trochlear nerve is going to innervate the superior oblique muscle, and when that trochlear nerve sends a message and the muscle contracts, then the eye is going to go down and out for its visual field. The other extrinsic muscle of the eye that is not innervated by cranial nerve 3 is cranial nerve 6, abducens or abducent nerve. It causes abduction of the eye or lateral gaze of the eye. The only muscle innervated by cranial nerve 6 is the lateral rectus muscle found on the lateral aspect of the eye. Cranial nerve 5, the trigeminal nerve, 3 branches. You've got the ophthalmic, maxillary mandibular branch, or V1, V2, V3. That's going to be sensory into the face. So if you close your eyes and you say to your patient, can you feel this? Does it feel the same on both sides? That's testing cranial nerve 5. Trigeminal nerve, motor innervation, like muscles of mastication, which include the masseter. So if you clench down really tight, you'll feel the masseter right here contract, the temporalis muscle, the TMJ. That was cranial nerve 5. Cranial nerve 6, we talked about lateral rectus. Cranial nerve 7 is taste sensation in the anterior 2/3 of the tongue and the muscles of facial expression. So raise your eyebrows up, smile, wiggle your lips. Those are all innervated by cranial nerve 7, as well as the anterior 2/3 of the tongue for taste. A couple other things innervated by cranial nerve 7, but for right now, let's just stick to that. Cranial nerve 8 is the vestibulocochlear, coming from the ear. So sound in and balance in. So wiggle your head around. There's an organ in your inner ear that is keeping track of all of those movements of the head, sending sensory information via cranial nerve 6, 7, 8. 8 goes into the ear. 9, pop that pill to the back of your tongue, sensory to the back of the flex, innervation to the parotid gland, and then we're going to talk about more of cranial nerve 9 next trimester, towards the back of the mouth. Glosso, meaning tongue, so the back of the tongue. Cranial nerve 10, this is sign language for 10, is the vagus nerve, the wanderer, the vagabond that wanders all over the body and innervates all the internal viscera, except for the descending. The cranial nerve 11 is spinal accessory, and so I had a dream last actually about spinal accessory nerve, and I know I mentioned frequently that 11 isn't like the rest of the cranial nerves, but it is important in functioning with the rest of the cranial nerves, especially 3, 4, 6 with movements of the eye and plexus. If a sound occurs on one side of the body, information coming in from the vestibulocochlear causes the eyes to shift their gaze in that same direction as the auditory input. Cranial 11 also plays a role in response to that auditory, that turning of the head is primarily done, at least in those really quick, mastoid and the trapezius as well. So even though it's anatomically it's really a it's really a spinal nerve. Cranial nerve 11 doesn't really belong with the rest of the cranial nerves because it behaves and it's differently. It's found lower down into the spinal cord, but whatever. It's cranial and whatnot. We'll just call it the odd man out in those cranial nerves. Cranial nerve 12 is the movements of the tongue. So movements of the tongue, hypoglossal nerve is going to innervate all those movements of the tongue. So think about eating or talking and visualize what your tongue looks like inside your mouth as you're forming words. All of those movements of the tongue are cranial nerve 12. Those movements of the lips are cranial nerve 7. Opening and closing that jaw, especially closing that jaw while you're talking, that's cranial nerve 5. Muscles, mastication. I know I missed a few things, but does anybody have any questions right now?
Do you mind quickly talking about those splanchnic nerves a little bit again?
Oh, yeah. For right now, I would like you to know that splanchnic nerves are headed to the viscera. I would like us to know that the thoracic splanchnic nerves include greater, lesser, and least splanchnic nerves. Beyond that, you're going to get more detail on splanchnic nerves with Dr. T. I just wanted to introduce the concepts, but it is really unlikely. You might see one question on the final exam. I take that back. There's one question on the final exam that asks about segments that make up a splanchnic nerve. I would also note that all of the splanchnic nerves are sympathetic except for the pelvic splanchnics. S2 through S4, those are the parasympathetics to the genitalia. and the distal colon and rectum. So while you're social distancing, when you guys eat, when you look at something, when you chew something, when you talk, when you move your arms, when you move your body, when you move your legs, when you walk, when you go upstairs, when you go downstairs, I want you to think about your x-ray vision. I want you to practice palpating. I want you to verbalize to yourself like you're teaching a patient, even teaching a patient in a virtual setting like this, which would be under the category of telemedicine. How much about the body do you already know that you can explain? If there's an area of the body like the shoulder, the elbow, the forearm, the arm, the vertebral column, if there's something that you can't explain from an anatomical standpoint, take a few minutes to review that and that part of your body, because Gross Anatomy 1 is all about movements of the body. How nerves get there, how do those muscles attach, where do those muscles attach, what do those muscles do, what happens to those joints. That's how we should be reviewing the content for Gross Anatomy 1.
When you were going through the flexor reflex, you said that from that interneuron you're also going to have a conduction over to the other side of the body. Is that just in reflexes that would involve that crossed extensor, so like stepping on a Lego?
So yeah, good question, James. Mike. So in that flexor reflex, in that demonstration, we saw both things. So in the crossed extensor, like I'm walking along here and I step on a Lego, I have a flexor reflex with this leg. I've got a crossed extensor reflex with this leg. This flexor reflex is a monosynaptic ipsilateral reflex. The cross extensor reflex, which happens at the same time, involves the interneuron and the crossing over to the other side. That's a polysynaptic reflex because of the existence of that interneuron between the two sides.
Is that just going to be for lower body though? So like if you touch something hot on the stove, are you still going to have a conduction to the other side of the body despite the fact you don't need a support in your other arm?
Really good question. Yes, we see it especially in babies, in newborn reflexes. You'll learn about this later on when you get to maternal and child health, but there's a fencer response or a fencer reflex that occurs in babies where they'll flex one side and then they shove out their arm, stick out their arm with the other side. And that's a normal reflex in babies, where you've got a flexor withdrawer reflex on one side and a fencer extensor stance or result action on the other side. So it does happen in areas other than the lower extremity. Yeah. There's also a contralateral reflex that occurs in the ears. So when you're exposed to a really loud sound, like we have a sound on one side of the body, in that reflex response, to reduce the amount of excessive movements of those tiny little bones in the ear that we're going to learn about next trimester, there's a tiniest muscle in the human body called the stapedius, which is also innervated by cranial nerve 7, tensions, and it reduces excessive movements on the stapes, one of those 3 tiny little bones or ossicles in the ear. At the same time that happened on this ipsilateral side, there's a contralateral reflex to the other side, to the stapes, to the stapedius muscle as well, that contracts and reduces excessive movements on the other side to reduce the volume of sound that is perceived. So we see those cross reflexes involving both sides throughout the body, just to help us understand like the really basic fundamentals of it. Is why I like to use the lower extremity, because I think everybody has stepped on a Lego or something sharp at some point in their life, and that's why.
I had a question about so when like a sympathetic or comes out of a sympathetic postganglionic neuron comes out of a gray rama communicanta, could that go either anterior or posterior divisions of the spinal nerve? Or I was kind of confused about that.
Yes, it, it has to be able to go. Turn your microphone off.
Sorry.
That's all right. It has to be able to go through the ventral and the dorsal primary rami, because those postganglionics are going to go to sweat glands at the dermatome distribution levels. And all of those sweat glands along the back are going to be innervated by those postganglionics that get there by exiting the gray rami and then going into the dorsal primary ramus towards the intrinsic muscles and skin overlaying the back. Good question.
Thanks.
All right. Move your bodies around for the next couple days. Practice some metered breathing. So slow respirations in, and then even slower exhalation, respirations out. As long as we're talking about breathing, we talked about muscles involved in breathing. We had the respiratory diaphragm that's innervated by phrenic nerve, C3, C4, C5, and the external intercostals, internal intercostals, and then innermost or intercostals. Those, my fingers, of course, describing the orientation of those muscle fibers, external oblique, internal oblique, and oh my God. And how about external intercostals, internal intercostals, and innermost intercostals? Yeah. Move your bodies. Have fun. Wednesday, since it's just 24 hours before the lecture and lab final, or right about 24 hours before the final exam. Wednesday is mostly going to be a Q&A. So use your bodies in the next 48 hours. Come with some questions on Wednesday if you want. And then if I don't see you Wednesday, I will virtually see you Thursday for our final lab and our final lecture exams. Whoever started the recording, you can stop that now, and then I'll upload that as soon as it gets processed, and I'll put the link to that recording in Moodle.
Could I ask one more conceptual question?
Yeah.
So you have your spinal cord, and then your lateral horn is where you said all the sympathetics are. But in everything else, you have everything leaving through the two horns, and then going down, and then it goes up through your white rami communicantes into the sympathetic ganglia. You with me?
Yeah, I think so.
So where are your sympathetics actually processed? Is it in that lateral gray horn, or is it in that sympathetic ganglia outside of your spinal cord?
Good question. So the sympathetics all start in the preganglionic fibers. The cell bodies of those preganglionic fibers are found in the lateral gray column, or the lateral horn, between T1 and L2-3 spinal segments. And so from that lateral horn, then all of those messages are going to go out through the ventral root from the spinal cord. From that ventral root, they're going to join the mixed spinal nerve. That mixed spinal nerve is where the ventral root and the dorsal root come together. That dorsal root being sensory, the ventral root being motor. Between the levels of T1 to L2-3, that ventral root, or that anterior root coming out of the spinal cord, is going to carry GSEs to all of the skeletal muscles and preganglionic sympathetic fibers between T1 to L2-3. That preganglionic sympathetic fiber leaves the mixed spinal nerve via the white rami communicantes. It then enters the sympathetic chain ganglia. And it is in that sympathetic chain ganglia that sympathetic neuron, or that axonal fiber, can ascend up into the neck and into like the superior cervical ganglion. It's going to synapse in that superior cervical ganglion, and then the postganglionic sympathetic is going to go into things like salivary glands, the intrinsic muscles of the eye that are going to allow that iris or that pupil to dilate and open up, allowing for more sensory input. And it's going to change the vascularization to the eyes, to the ears a little bit as well. But where does the processing of that occur? I think that question requires more information beyond the general anatomy right now.
Okay, that's fair.
All right. If there are no other questions, thank you guys once again. You're phenomenal. I've been informed that all of you guys have received an email that the first 2 weeks of next trimester will be delivered remotely. Doctors Muldoon and Peterson and myself are going to work tirelessly over the break to have a really seamless first couple of weeks of content that will start with a virtual dissection of muscles of mastication, the eye and the ear. When we make it back to campus, then we will be ready to start with dissection. We'll do we're going to save the paraspinal dissection for the end of Gross Anatomy 2, because it'll go along really well with our spinal dissection at the end of Gross Anatomy 2. But all of that content for at least the first 2 weeks next trimester will be virtual content. We'll have some lab activities for you guys to do at home and some virtual dissection. So until then, stay away, stay home, wash your hands, wash your face, do healthy things, eat healthy, make sure you get outside, but not too close to people. And wear some sort of mask while you're outside. If that's a t-shirt that's rolled over and tied around your mouth and nose, then do that. But stay healthy, because after we resume some sort of normalcy after this, we're going to need to be further along in our process of delivering highly effective, conservative treatment to our future patients. I thank you guys once again. You've been phenomenal. I'll maybe see you Wednesday. Otherwise, I'll see you Thursday for the final.
Thank you.
Thanks, Dr.
Thank
Farrar.
you guys.
Thank you.
I miss you guys.
Thanks for
There, Dr. Farrar.